that of the tachycardia, hypertension, dehydration, obviously depending on the severity of the hemorrhage, patient may remain unconscious. This is one, but again then, as because I have told you that these days, because of the different other parameters, other reasons like different drug use, so ectopic pregnancy could be uncommon type. Uncommon ectopic means non-tubal one. Non-tubal one means that can be there in the ovary, that could be there in interstitial portion of the fallopian tube, if there in the cervical region, there could be ovary, there could be abdominal ectopic pregnancy. The reason I am telling you, once you are in the clinical field, unless you keep your mind open that whatever could be, you miss the diagnosis. And it is such a situation, missing the diagnosis often ends in death. Next. If we give you some risk factors, in our time that main risk factors was pelvic infection. That I have written that where it is PID, pelvic inflammatory disease, chlamydia, you will go to the textbook, the same sort of reason has been there, etiological factors. But as because I have told you, lifestyle changes are there. Because of the lifestyle changes, there are other reasons for ectopic pregnancy. If she has got a prior ectopic pregnancy to the extent of 12.5%, for your MCQ, question will be there, answer will be there, the prior ectopic is the commonest one. But our standard day-to-day Indian system, pelvic infection, pelvic inflammatory disease, especially the chlamydia 3.4, prior tubal surgery 4, tuboplasty, smoking, not that common in our situation, but again then more than 20 cigarettes, this is these days, you have to go by the guidelines, what they are telling. Prior MTB, some abortion, some curettage, D&C, history of infertility, yes, prior IUD, MCQ is very confusing. Prior IUD to the extent of 1.3. Ovarian pregnancy is rare, but again then, there is now such bar that pregnancy could not be ovarian pregnancy, it could be there. And these days, additional features is that, don't forget that one, ART, assisted reproductive technology, meaning that pregnancy following IVF. IVF in ET, this is going on all over the world, so also our country, so also in India. So ART, low BMI patient, they have got the higher risk of ectopic pregnancy. Next. My interest with this, when I was a registered at Nilatan Sarkar Medical College that I told you earlier, Indian Medical Gazette, good popular news journal that time, I published this article, 1986 NRS Medical College, bottom, that pregnancy is 1:1.76. Out of 1.176 patients has got the risk of 1. And before me, 1968, one of our teacher, sir would be knowing, Professor Lahiri, B.C. Lahiri, Professor Bhavesh Lahiri. No. ওখানে যাচ্ছি না তো ওখানে স্ক্রিনে ফেলতে পারছো না এ তো ডার্ক আছে তো কিন্তু স্ক্রিনে পড়ছে কি দেখো স্ক্রিনে যখন যাচ্ছে না ওখানে দেখা যাচ্ছে না পয়েন্টার হলে বলো তো আলাদা যেগুলো থাকে সেই জন্য কাজের না anyway I'll go slow. There is an arrowhead. Nilatan Sarkar Medical College that he published to show that the NRS Medical College, a huge number of patients catering that time. We used to go patients from the northern region also. That was 1 in 176 pregnancy, one is ectopic. My good old teacher, Professor Lahiri from Medical College, Indian Hospital is that of the Medical College, that has given the ratio 1.183. More or less the same. Next. Uncommon ectopic pregnancies, challenges in the management. Ectopic pregnancy diagnosis is a challenge. Again, then if it is an uncommon variety, non-tubal variety, then it is a bigger challenge. Unless you are very careful and in an analytical mind, what is the presentation? Listen to the patient, that will help you the more. Uncommon ectopic pregnancies, challenges in the management is difficult. Now then, what are the uncommon recurrent ectopic pregnancies? Ectopic pregnancy, again the woman can have the another ectopic pregnancy. 3 times recurrence I have seen. In 7 cases, 3 times. Third time recurrence, 7 cases ectopic pregnancy. And familial ectopic, I don't know, that is not in the textbook. No research work has already established. But I have got 2 sisters, family, both the sisters suffer from ectopic pregnancy. Unfortunately, recurrent ectopic, and they lost both the tubes. So this is the type, once you focus one subject carefully, you will learn more. So this is the, in our perspective, recurrence is there, and familial ectopic, it is not established in the textbook, in the research work. But I have observed 2 sisters, recurrent pregnancy and recurrent dual ectopic pregnancy. Next. Changing trends in the management of ectopic, the incidence of ectopic is rising. This is totally true, that use of different methods, late marriage, pelvic infections, different methods of contraception, lifestyle change, all are rising. Early diagnosis is possible. This is, I told you that beta ECG, if there is phases of amenorrhea, even few days over, if you go for the test for beta ECG, 1500 intracellular per milliliter, you go for that, or pregnancy test, USG can make the diagnosis by 5 weeks time. So by phase of gestational sac or by laparoscopy. So with the advent of all these progressive investigative measures, we can make the diagnosis of ectopic pregnancy early. Diagnosis before the stage of rupture, yes, that could be made. I will show you that what we have done. I will show you the pictures. Management options, ectopic pregnancy management options is that basically is the salpingectomy. If you want to pass the examination, salpingectomy. That you are sensible doctor, you like to save the patient, salpingectomy. But there could be conservative management also. That will come. But again then, for you, if you like to save yourself from the fail or pass, salpingectomy. Or if you like to get the honors mark, then you stick to that. Salpingectomy is one option, but that could be, depending on the situation, other modes of therapy. That I will tell you also. Management options, conservative, that I have written. Diagnosis before the stage of rupture is the good point. If we can make the diagnosis before the rupture, then your patient has got the benefit of preserving the tube. And if the tube could be preserved, so the chance of success next pregnancy is good. So conservative management, medical management, surgical management. These are the different improvements in the management of ectopic pregnancy. You can go by the conservative, you wait. If the beta is falling down, you wait. Pregnancy may regress. So there is no such risk. Or we have got the different drugs like methotrexate, potassium chloride. You can use and then destroy the pregnancy. Tube will be protected, patient will be saved. Or the surgical management. Surgical management commonly we have done long before and then also, now also. Only thing that we have done the laparotomy earlier days, now we are going for laparoscopy. So this is the change in the management of ectopic pregnancy. That as a student, even the UG students should know that laparotomy, laparoscopy, these are the different modes, or medical therapy, there are different modes of ectopic pregnancy management. Now survival rate, yes, survival rate has improved, and reproductive outcome has also improved. If you can preserve the tube, for her, the chance of successful pregnancy next time is high. So think of ectopic pregnancy unless proved otherwise. This is the dictum written in the textbook, and from our student life we have heard, and he has warned all the gynecological professionals all over the world that 3 things present exclude ectopic pregnancy first. Be ectopic minded, meaning that keep in mind that ectopic mind could be a possibility and exclude it. So save the life of the patient. Uncommon clinical scenario, if you feel that the telltale picture is not that I am talking of, amenorrhea, pelvic pain, vaginal bleeding, this picture is not there, sometimes deviation, think of ectopic, exclude ectopic pregnancy. Next. Different modes of diagnostic you see, beta ECG, USG, Doppler study, USG. This is the Doppler study. This is said as the ring of fire. You see, with the Doppler study ultrasonography, this is the tube. This is ectopic pregnancy. Perivascular, pregnancy, vascular filling. All the blood vessels of the mesochondrial tubal vessels are enlarged and highly vascular. So, ring of fire, this is the term used ultrasonography, and you can go for the laparoscopy. So, serological test, blood, ultrasonography, Doppler study, and the laparoscopy. Next. Laparoscopy view. Here is the uterus, telltale picture of this blotchy hemorrhagic tube. femoral end of the tube, and here is the ovary. Right ovary, uterus, femoral end, and the right ampulla with huge amount of collection of blood there. Laparoscopy, once we have that, I told you that we used to do huge amount of laparoscopy at one time. It's very easy and make the diagnosis, but it is an invasive procedure. If you can make the diagnosis with non-invasive procedure, always better. Otherwise, you have to go for all the risk. Next. Laparoscopy procedure of doing surgery. These days, we have changed from laparotomy to laparoscopy, where facilities are available. So we are doing that of the uterus. On the left-hand side tube, this is the left-hand side tube, that uterus, round ligament, ligament of ovary. This is the tube. This is the tube, and the ectopic pregnancy is there. We are salpingostomy. This is the salpingostomy, this is the uterus. On the right-hand side, tube normal. So we are going for this salpingostomy to take out the product of conception and leaving the tube. That is known as salpingostomy. We don't repair the tube. It is said that it heals spontaneously. That we do. So I did that one also. Next. Uncommon ectopic pregnancies. As I told you, I have got a record of all these ectopic pregnancies that I have come across all over the centers that I have worked. Huge number. That this is the Journal of Gynecology. This is a recorded paper. Often I get invitation to talk about this ectopic pregnancy in different parts of the world even, because of this publication. Next. Interstitial pregnancy, meaning that it's uncommon in the sense that tubal pregnancy is common, but interstitial part of the tube pregnancy there is uncommon. And this interstitial pregnancy has got a huge risk. It is the highly vascular part of the uterus, and if it ruptures, huge amount of bleeding, and then patient often dies undetected. So unruptured and ruptured, two varieties could be there. Management of 3 cases, and I have got this series. So next, we will cut it short for you, not to go for the detail. One is that diagnostic criteria is difficult. Usually rupture occurs late 10 to tubal pregnancy 8-10 weeks. Here is 10 to 16 weeks time, because interstitial portion of the fallopian tube has got a huge amount of muscle there, and the thick muscle there has got huge vascularity. It allows the pregnancy to grow. At one phase it ruptures. So it's a late rupture. Asymmetric uterine enlargement, and anatomically it goes lateral to the round ligament, the interstitial part of the tube. Interstitial lines, and I will show you the ultrasonography. Problem is that if it ruptures, huge hemorrhage. I will show you the case that I was asked for. Laparotomy or laparoscopy could be done. Corneal resection, corneostomy, medical management. Well, early diagnosis, it could be treated with medical management also. Like methotrexate for some period could be given. Mortality is high. If interstitial pregnancy is diagnosed late or missed, mother dies. Next. Interstitial pregnancy, this is the ultrasonography. Interstitial pregnancy is there in the corner of the uterus. And this is the endometrium that I have shown. Next. This is called the interstitial line sign. You, for your study, postgraduate, you have to talk about how the ultrasonography can make the diagnosis of interstitial pregnancy. Interstitial line sign, echogenic line within the cavity of the uterus. Pregnancy is there in the interstitial part of the tube. Cavity is empty. That interstitial line sign is there. Next. Interstitial pregnancy. This patient, to tell you the history, she was with me from Tripura, infertility, all the investigations, and then with her attempt, she conceived. She left Calcutta, went for Tripura for the rest of the management once pregnancy confirmed, and she left. Few days later, she called me that she is having some pain. So pain, then I said get the local gynecologist, obstetricians, and that of the sonography it could be. But they could not take the diagnosis again then. I said there's nothing alternative, you have to come back. So she flew back to Calcutta, and then pain increased. I said, you go directly to the hospital, and I advised them to go for the sonography. Sonographer told me, Dada, I can't understand what it is. But cavity, there is no such pregnancy. But the uterus looks like I am not quite sure what I am dealing with. So best thing, I said, admit it, get the theatre ready, we should go for this laparoscopy. Laparoscopy, this is the interstitial pregnancy, this is the bulge. And we are placing the suppression operation, we are putting there to reduce the vascularization, and we did the salpingostomy. So it is the interstitial pregnancy. Unless detected early and timely, rupture is there and huge amount of hemorrhage. Next, so salpingostomy, we are suppressing devascularization and making a puncture and aspiration of the product of conception. We are using the sucker to take out the product of conception. Next, this is one interstitial pregnancy. All the obstetric emergencies sometimes in the middle of night. It's my experience of. I was called when I was in the campus middle of night around 2 o'clock. I was called Dada. No, I was not allowed to use change my clothes. So Dada, okay, no change. You come straight. I was in the quarter there in the circle. The house surgeons came to pick me up. Dada, apni cholun surgical theatre. This is not in gynecology. Surgeons open up the abdomen, laparotomy. They have looked for everything. They could not find any blood. Patient is huge hemorrhage, and then they were puzzled. So they called me Hiralal immediately. Senior surgeon asked me. So I didn't have any time to change my clothes. I was about 10 minutes changing there in the theatre. Anesthetist called me, don't need to come. There is no need to coming here. There is no pulse. So there is no better not to waste time, just take the patient down, close it down. Meaning that patient is pulseless because of massive hemorrhage, so there is no need of going for further. But surgeon said, Dada, nothing doing. You come down and have a look. So somehow I immediately changed and got in, and I immediately put my hand because I knew surgeon has explored the liver and gallbladder. This is the main cause of surgical hemorrhage. Spleen and the gallbladder is there. So, and the liver rupture, trauma. So there is nothing. Surgeon has also, only I put the hand in the pelvis and pulled the uterus out. I could say, Didi, give me 2 minutes only. Rather than 60 seconds, give me 2 clamps. Immediately put the clamps and did the subtotal hysterectomy. Patient was saved. So this is the interstitial pregnancy that never took a hot place. Never. Sir used to say, keep in mind, you think of ectopic pregnancy, you get the result. And it's a magic. If you can right time, you can go for this hemostasis, patient will survive. Next. Cervical pregnancy, again, this is a, I am not going to the theoretical part because when you become a postgraduate, you need to go through. That you know that very rare, 1 in 16,000 pregnancies. And rising because of ART, assisted reproductive technology, IVF. And diagnostic criteria, but also in the case of emergency, criteria to tell picture that it is not there. So Robin's criteria is there, and then different modes of treatment. But I will be interested to tell you what I faced and what I did. This patient, next one. This patient, this patient was diagnosed as a case of cervical abortion. You see, intrauterine pregnancy, and then product of conception has come down to the dislodge and come down to the cervical canal. Cervical pregnancy, there is a term, cervical abortion. It was clinically diagnosed as cervical abortion. She was put it in the for DNC in a major theatre that we had the same in Lusaka Medical College. 3-4 major cases. At the end, she was there. 3 o'clock, she was taken to the theatre table. When I started doing the evacuation, patient started profuse bleeding, and patient went into shock. God forbid. Anesthetist and team were all there by the time. So immediate resuscitation. And I kept firm pressure by manually to control the hemorrhage. By God's grace, bleeding was controlled, and then we started transfusion, and I could realize that there is something emergency. So at the moment, odd hours, around 3:30 in the afternoon, again then to go for hysterectomy with everybody is exhausted, a long theatre. So we somehow control the bleeding, blood transfusion, and then we put her conservative management and put her the next third day for this of the OT. With resuscitation, ultrasonography, possible like beta ECG positive, and then we did laparotomy, and you see telltale picture, this is the cervical pregnancy. You see, this is the external loss. You see, this is the external loss, this is the developed internal loss. Pregnancy is there in the cervical canal. Cervical canal is ballooned. The external loss is opened up. So this is the cervical pregnancy. Uterine cavity is empty. That cavity is empty. So this is the cervical pregnancy. Very rare, 1 in 16,000. And diagnosis is very difficult, and then death is very high. Resuscitation, blood transfusion, laparotomy, later death, and we did this total hysterectomy. And it has got some standard criteria to define what is cervical pregnancy. All the criteria fulfilled, it is a cervical pregnancy. Next one. Heterotopic pregnancy means there is double pregnancy. One is there in the uterus, another is there in the fallopian tube or somewhere else. So this is the problem. This is a heterotopic pregnancy. This is, with the advent of ultrasonography, serum beta HCG, MRI, we are diagnosing all the types of ectopic pregnancy that were not diagnosed before. Earlier it was not. So patient often used to die without any reason or explanation. Heterotopic pregnancy combining of nearly 60% or 70% depending on the institute. So because cesarean section is rising, there is a problem of cesarean section scar 2 to 3 times, and sometimes the blastocyst, the following pregnancy, Konar pregnancy. This is from North Bengal Medical College. So I tell you what is the next? I tell you why. This is the case that I told you earlier, Kokrajhar. She came I told you during my presentation, she came from Assam to Coachbihar to Siliguri General Hospital, then Medical College, and then everywhere she received situation for induction of labor, nothing doing. So ultimately I said this is the case of abdominal pregnancy. I did the laparotomy. You see, this whole skeletal mass was there in the abdominal cavity. All macerated tissues are macerated, and then the tissue absorbed, and the skeleton is only left behind. Extremely rare. I have not seen such an experience in the world literature. So that's the reason it is special for us. So repeated failed induction of labor, this is such of cases, and then laparotomy, whole skeleton has been taken out and reassembled again, and I have taken the photograph. So this is the abdominal pregnancy. Next. Abdominal pregnancy as an emergency. So admission as F36 labor pain. This is one that I tell you. This is very another interesting. Even it is 2018 that I faced this problem. Now we have such a case. Somehow you have to help her. So I said, let the patient come. You ask the blood bank to get ready, and my team anesthetist should be there so that we can proceed. Senior anesthetist, and I need some assistance also. Good. So everything organized. So abdomen closed, the body pulls, and referred to CNMC with a special message health tools arrangement. Next. And I did the laparotomy. It took nearly 4 hours. Meticulous resection wall to all, and next they appreciated it. So we are very happy. Next. Next. Here is a tubal ectopic pregnancy. This is see, tubal ectopic pregnancy is there. But tubal ectopic pregnancy, the tohoblast tissue underwent malignant comments. This is basically by that of the Professor Dishdatta. He was very expert surgeon, and his intuition probably was very high. He used to speak very less, but he would look at you for a long time. He will look at you and make some conclusion that is a definite. So this is some additional, maybe some additional power for some special persons. What I have written, the knowledge, surgical skill, and the awareness, ectopic minded. He used to say of this word, you should be ectopic minded, otherwise you miss the diagnosis. And once you miss the diagnosis, you face the death. Earlier there was many deaths I have seen. So it has gone down now because of this awareness, because his effort to be ectopic minded. So this way we have done. So knowledge, surgical skill, and the awareness, ectopic minded, to raise the suspicion, then you satisfy yourself, are the more valuable other than to seek for higher grades of investigation. There are tendency, clinically, go for the beta ECG, go for the ultrasonography, go for the CT, go for the MRI. Going one to another investigation, there is no need. Unless you are clinically sound, you are wasting your money and time. So, investigation for the confirmation and to cause delay in the management. Ultimately, you are making delay in the management, and then ultimately you are losing the patient. Next. This is the last word that I have written in this chapter. One should not be ashamed of negative laparoscopy. He used to say, even if you go for laparoscopy or laparotomy, if you see healthy, this is better. Rather than keeping everything alive as it is, without making any effort, and losing the patient at the end. So patient, I have seen in North Bengal Medical College, in Calcutta also, medicine ward, patient is admitted in the basic medicine ward, and then keeping on conjunctive management until the patient dies, and then go for postmortem or hue and cry, ectopic pregnancy. One should not be ashamed of negative laparoscopy. Even if it is laparoscopy, you suspect ectopic, you go for laparoscopy. If it is negative, he uses it is better. If laparoscopy is negative, it is good. You save the patient. But otherwise, if you don't suspect the ectopic patient, if the patient dies, that is a shameful job. So one should not be ashamed for a negative laparoscopy or laparotomy rather than to regret for eventual fatal outcome due to missing the diagnosis. You missed the diagnosis, you never thought of, and the patient died. That's a shameful job. So, D.C. Datta, I have written his word. I have heard him telling a number of times. D.C. Datta, the teacher and the author. So this is my last slide. Next slide, please. Well, I have got the video. Can you play the video? Double click it on the double. You have to click double on it. Anybody here? You see this? This is the patient that came from. No, this is not the Tribunal. This is another patient. Massive hemoperitoneo. Middle of night again. Patient is hypotensive, collapse nearly. Usually it is contrary. If the patient is hypotensive, tachycardic, and ample part of the fallopian tube, and the ovarian vessels are there, and the uterine vessels are coming. This is the junction point, highly vascular. And what is the liver? This is the liver bed, this is the gallbladder. You can see all the abdomen is full of blood. Subhepatic, upper abdomen, and we put it head down. So all the blood collects from the pelvis to the upper abdomen also. Now we have made the dissections, and now tube is cauterized. Once the tube is cauterized, you are in the safe side. There is no further. We are cutting the fallopian tube, salpingectomy. You see the lumen is there. Now we are going to this mesosalpinx. So lateral line and then the medial line, salpingectomy. Now we're putting the polythene.
Internship area. Probably sir won't recognize me, but I happen to have Dr. D.C. Datta. When she is about to retire, his first edition of that book was about to be published. It is in I think 1993 or 4. Sir, আমি এনএসএ ছিলাম। I did my MBBS. I entered in 1988. I passed 1993. Yes. I did my MS also in NRS. I passed 2000. So, আমি স্যার আপনাকে খুব ভালোভাবে চিনি। So, what happened? That is one sort of I am still in the internship and having a class of ectopic pregnancy. Sir বলতেন যে clinical thing. Even my students will know clinical thing is a lost art. But I still now I depend on this thing. Because I tell them that is we are supposed to do what Sherlock Holmes is famous for. That is depending on all the clues. So this is definitely one thing. Another thing is my experience is serendipitous. She called me, sir, there is can you come? So I sort of avoided it. But ultimately I came and it was a real experience. And sir, two, three things I'd love to tell you. That is general surgeon is actually they had to do ectopic pregnancy, and in our MS ship we did, and salpingectomy and all these things. But few interesting things, that is few confusing things. One is patient already ligated and came to me with features of ectopic pregnancy. Another thing, patient is widow. Or patient is widow. Think of that critical situation, how to counsel. When you are suspecting ectopic pregnancy, you don't have the liberty of ultrasonography. And another is patient has already undergone ligation 1 year. So even I was so confident of my clinical thing, I operated, and when I was operating, some phone call was there to the anesthetist that gynecologist was confirming whether the diagnosis was confirmed or not, because patient party has already sort of threatened that gynecologist, sir, you did think, how come patient became pregnant? So this sort of things happened. So, and one other thing, the same symptoms, there was no radiologist available, but then one technician was there. So I tell him, can you sort of give me some idea he used to assist the sonologist. Just tell me whether uterus is empty or not. So pregnancy positive, history of amelia or spotting, but uterus is empty. So think of ectopic unless proved otherwise. Yes.
Sir, বলছেন।
Thank you, sir, for your very good presentation. Another thing I will add, any patient, not only in surgery, in medicine ward, admitted with pain abdomen, in the reproductive age group, you should do first pregnancy test.
Exclude, yeah.
It is a experience of us. There are several patients admitted in medicine ward with abdominal
Absolutely,
pain.
very true, very true.
Patient was an ectopic pregnancy is there. So it is already sir is told যে ectopic basically তো মাইন্ডেড হতে হবে
একদম।
আর এনি ওই যে স্যার যেটা বললো একটা হিস্ট্রি রিপ্রোডাক্টিভ এজ গ্রুপ পেন অ্যাবডোমেন অ্যামেনোরিয়া সেদিন আমার ইন্টার্ন বলছে স্যার আমাকে পেশেন্ট পার্টি কি গাইনোকোলজিস্ট দেয়নি দাদা এটা দেবে না এটা দিয়ে নিতে হবে বের করে নিতে হবে একটা পেশেন্টের প্রেগন্যান্সি আছে কি না আছে সে কি নিজে বলবে যে আমার ও বলছে যে মেনস্ট্রুয়াল হিস্ট্রি ওইরকম না কিন্তু জিজ্ঞেস করতে হবে অ্যামেনোরিয়া তোমার লাস্ট ডেট কবে হয়েছে কি না হয়েছে সেই জন্য শুধু ectopic pregnancy not only surgery not only gynecology it is also important in medicine ward.
Sir, with permission and between us, I have seen death in medicine world, not Bengal Medical College, and ultimately postmortem proved that I'm ectopic pregnancy. So we should be very much. Sir, what should I say? Ectopic minded. Take it as ectopic pregnancy unless proved otherwise. Unnecessary laparotomy is accepted other than the death of the patient. Even if it appears that the laparotomy was unnecessary, still it is rewarding than allowing the patient to die with ectopic pregnancy. Very important. That's the reason I thought this is a simple subject, but everyone should know. But it has got nowadays, it has expanded with that of different types of ectopic pregnancy. But common things, common. We should know the common things. We know how to manage the common things and the arrangement.
Students can, if anybody have any questions for the sir.
Comment.
So one thing I have also an experience about that, about this very thing.
স্যার আমার একটা কোশ্চেন ছিল আচ্ছা স্যার তো একটা পেশেন্টের
I have raised some curiosity around.
স্যার একটা পেশেন্টের আনরাপচার্ড একটোপিক প্রেগন্যান্সি আছে আর তার ফ্যামিলি কমপ্লিট হয়নি হ্যাঁ তো সেলফ ইনজেক্টমিটা কি করা যাবে এই ক্ষেত্রে
That's true. You see, answer to the question is difficult, but you need to discuss in detail before you put into another problem of litigation these days. Very, whatever you are, the earlier days when I started, it's a different thing. What I said, God is saying. So they accept you everything. That I have shown you in the morning hours, number of cases. These days, if the undoubted ectopic pregnancy, and then what should I do, subjectomy or management is that if the situation is unruptured and location, depending on the location, if the tube could be salvaged without any damage, while with a prospect of next pregnancy, successful pregnancy, probably we have got the alternative of something gustard, meaning that laparoscopically you open and make a little, I think that could be a video, make linear incisions of the ectopic site and take out the product of conception and vulgarize that to bleeding points. Leave it alone. It will heal of its own and tube remains functional. But for her, the other tube, it is normal. Doesn't matter. If you do the supplementary, you got the benefit of getting the healthy tube conception. So that's, but if she wants to use a written document, counseling and documentation as per desire of the husband, benefit of the endoscopy has been discussed and agreed so that both we are safe. Otherwise, later on some problem again, the victim is legal. 100% that you will see that granted that
a patient presented with hypotension, and she has already received three IV fluids, 3 units of IV fluids from outside hospital. But in spite of the fluid, her BP was so low, 90 by 50 or 90 by 40. Yeah, and yeah, and she was not passing urine. Okay, so we could not perform urine test. But after 3 or 4 hours, she was put on catheter, and from the Eurobag, we performed at around night at 12. The UPT came positive, and it was found to be ruptured ectopic, and she was operated. And said, how can we? Is there any other method that we can, if she's not passing urine, can we perform?
No. Not passing urine. Urine is there in the bladder. She is not able to passing urine because of this spasm, pain, and hypertension. She is drowsy. Also, maybe she has received some sedation. So she is physically unable to have the reflex of exudation. So this is the situation your patient. She has lost the sensation of. She is physically unstable. She has lost the desire of menstruation because of this hypertension, hemorrhage, anemia, weakness combined together. So this is the situation. But obviously, such a situation that pain, hypertension, tachycardia, and then some melodia in a female patient should be better to go. This is very easy. The kit is there, so take a sample of urine and go for the test. Patients are doing themselves. Often they come, I have done this test and it is positive, it is negative. From our side, that's the reason this topic I have taken. For all our people, from the beginning, we should be geared up that emergency situation has to be tackled with some way or other. This patient, younger patient, epileptic is that of this history of pneumonia, spotting, go for a little bit of pain after be ectopic minded, do the test, and then you go for coronary. You exclude ectopic pregnancy, so the patient is otherwise catastrophic.
And sir, 5 months ago, another patient has presented with CBG around 600 and pain
CBG?
Yes, sir.
Oh,
Capillary blood glucose 600, and we suspected decay, new onset decay. So we treated and along that line. But she was also hypotensive and not passing urine. But after a day or half, we were tested UPT and it was again positive. And then she was undergone laparotomy. Laparotomy was successful. The patient died.